So now we're going to be talking about Module 43, which is evaluating psychotherapies. Now that we've learned about different types of therapy, we have to learn about how to know which ones work. So there are different ways to measure the effectiveness of psychotherapy. Obviously there's client satisfaction, although I've seen clients who are satisfied who are not necessarily better. Whether the client themselves sees improvement in themselves, whether the therapist sees improvement in themselves, whether there's been an observable, measurable change by kind of more of an objective source in terms of the initial symptom presentation. So what causes improvement? So even if clients who go to psychotherapy improve, how can we attribute that change to psychotherapy? Could it be really due to a regression to the mean? So, for example, we've all had times where we feel bad, but then eventually after time it all kind of gets better. Or is it because the client is motivated to make a difference and just going to psychotherapy itself is a symbol of their motivation to change, and so they're doing it themselves and not just the psychotherapist? So one way to do this and to determine if it's a psychotherapy that's working is to study psychotherapy outcomes. So in order to track the effectiveness of an intervention, we have to use a control group who's either not receiving the intervention or even a placebo control group where they're receiving some sort of a kind of quote-unquote fake therapy, or not the therapy that we're trying to test. To measure effectiveness, we have to use objective, observable measures of the symptoms rather than relying on client or therapist perception. So this is where we have our questionnaires, behavioral measures, things like that. And so this is how we really know whether a therapy works. So if we find that people in a control group, or those who are not receiving therapy, for example, they're on a wait list, show improvement, is therapy a waste of time? Well, depends on how much of a change there is. For example, if you see the two graphs, the one on the right is people with that's kind of the peachish color, are those with who are getting psychotherapy, and on the blue curve are those who are being untreated. And so about 80% of untreated people have poor outcomes than the average treated person. So while on average people will get better whether they receive, or will get somewhat better whether they receive psychotherapy or not, about 80% of those who do not receive treatment have poor outcomes than those who do receive treatment. So basically what that means is that psychotherapy can help people, and it can help them get better faster. So we have different types of outcome research, and we found that there are different types of therapies that are found to be effective for different kinds of problems. For example, cognitive behavioral therapy is good for depression. Anxiety is also behavioral. Here they say psychodynamic. Phobia is exposure therapy, which is a behavioral-based therapy, and bedwetting, which is behavioral conditioning. So using outcome research in psychotherapy. And so what we talk about these days is using evidence-based practice, and this is the use of techniques that have evidence to support their effectiveness. And so anytime that I see a client, I will only use a technique that is shown to be effective for the treatment of the problem that they have. You'll see that a lot of therapists do not do this. They kind of use what they want to use, or what they feel, personally works best. To me, that's personally unethical. However, especially now that we have evidence to suggest that there are certain treatments that work better for certain types of disorders. So we do need to make clinical decisions based on more than just research. For example, patients' values, characteristics, preferences, and circumstances. We know there are different factors that affect people's response to different therapies. And so even though the research might suggest that something works, if somebody from a different culture or different ethnic background, for example, it may not work with them, and so there might be different things. We also have to think about the clinical expertise. I mean, if I have no expertise in an intervention, it's not ethical for me to do that either. But we also have to then take into account the best research evidence that's available. So how do we, when we have new therapies, how do we evaluate these alternative therapies? So, one of the problems is we don't know if cures for psychotherapy are actually caused by the intervention. And we also don't know how many people benefited from the intervention. So we have to do randomized control studies where we assign people to our treatment randomly, so kind of like, one person here, one person there, so we're not assigning based on personal selection or characteristics, and the other group is given a no intervention control or treatment as usual, and then we have to look at the outcomes to see whether there are differences between these two groups. And if our new therapy is effective, then we would see differences between these two groups. Now, there are obviously a lot of challenges, so we have to make sure the interventions are performed by people who are trained in that area, so that people who are doing the intervention know what they're doing. One therapy that's been very controversial is EMDR, eye movement desensitization and reprocessing therapy. So this is generally used for people with anxiety disorders, specifically PTSD. It was developed by Francine Shapiro, who is a psychotherapist out of California, and she one day realized that when she moved her eyes back and forth that she somehow was able to kind of feel better. And so what she did was then, working with her clients, she either used her finger or a light stick, or kind of like, if you, any of you ever watched Star Trek, you know how like Geordi has that thing over his eyes that the light goes back and forth. She puts that on her client's eyes, and then they follow the light, and then they talk about their traumatic memories. So this is basically exposure therapy, which is a behavioral or cognitive behavioral technique for PTSD. But in addition, she uses these lights, and she postulates that the fact that the clients are moving their eyes back and forth allows them to integrate the past and the present into the right and left hemispheres. So what the science says is that this treatment works. But it doesn't work for why Francine Shapiro says it works. It works because you're exposing people to their thoughts that they're afraid of, and has nothing to do with the eye movement whatsoever. That's just a gimmick. And so people are paying a lot of money to get trained in EMDR, and in actuality, it really does nothing above and beyond what normal exposure therapy would do. So basically, a lot of people are saying that it's a pseudoscience. There's also light exposure therapy. You probably heard of seasonal affective disorder. This is kind of depression that varies by season. So research supports the idea that daily exposure to bright light, especially with a blue tint, is effective in reducing the symptoms of seasonal affective disorder. So we do know that people who sit in front of these light boxes actually end up feeling better. So what do effective psychotherapy styles seem to have in common? They create hope because the therapist kind of instills hope within the client. It also gives people a new way of looking at their problems. And so you can help them with problem-solving technique. We also have the relationship between the client and the therapist, which is called the therapeutic alliance or the therapeutic rapport. And part of successful therapy, no matter what modality you use, is this relationship. So 20 to 30% of therapy outcome is due to the relationship between the client and the therapist. So therapists differ from clients in terms of their values, beliefs, culture, conversation style, and personality. And so we have to make sure that when we're serving our clients that we take this into account. So we always want to try to understand our clients and what perspective they're coming from. You know, I come from Canada, so my experiences are very different than people who grew up in New York City, and I need to understand how that influenced my client. Or if a client is coming from a different country or a different culture, how does that affect my client? Or if my client's a different gender or religion than I am. We can't make assumptions, because just because somebody comes from a certain culture, we shouldn't assume that everything that their behavior is attributed to that culture. So you need the client to kind of talk to you about what that means for them. So when selecting a psychotherapist, you want to make sure that you look at the degrees, because a lot of people with a lot of different training can provide quote-unquote psychotherapy. So it's important to kind of understand this. We do this for our doctors, but we don't necessarily do this for our psychologists or our psychotherapists. The most important thing, obviously, is whether you're able to establish an alliance with your therapist. And some of this is trial and error. Some people you're going to click with, some people you're not. You can try working it out, but it's also okay to switch therapists if you don't feel comfortable with the therapists. But you also have to be wary of client therapist training. For example, somebody who calls themselves a psychotherapist doesn't necessarily mean they're a psychologist. A psychologist means that somebody has a Ph.D. or a Ph.D. They have, and they are licensed in their state. Psychiatrists are medical doctors or doctors of osteopathic medicine, and they can prescribe medications, and sometimes they do psychotherapy. Generally, psychiatrists do not do psychotherapy, though. And some social workers, as well as counselors, nurses, and other professionals, may be trained and licensed to diagnose and treat mental health disorders. But anybody, regardless of their training, you know, anybody off the street can call themselves a psychotherapist. It's not any kind of a proprietary title, so you have to be very wary when you see that.